Hello, everyone. My name is Wendy Xie, and I am a project manager here at the National Collaborating Center for Infectious Diseases. I would like to welcome you to this webinar, Waves of Endemicity, Mathematical Models of Disease Persistence in Populations, hosted by NCCID. I would first like to acknowledge that NCCID is located at the University of Manitoba on Treaty 1 territory and the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. I am joining this webinar from Treaty 13 territory, the traditional lands of the Mississaugas of the Credit, the Chippewa and the Ojibwe of the Anishinaabe nations, the Haudenosaunee and the Wendat nations. Let us acknowledge the harms of the past and dedicate ourselves to actively work towards reconciliation through collaboration with Indigenous communities. NCCID is funded by the Public Health Agency of Canada to support the expanding area of knowledge translation and exchange of infectious disease research for public health. This includes mathematical modeling for public health and building awareness for the value of modeling research for infectious diseases. This work has included the creation of Mod for PH, or Modeling for Public Health, a discussion forum and virtual meeting place for public health professionals and mathematical modelers, summaries of COVID-19 modeling research in collaboration with the Public Health Agency of Canada, and an upcoming podcast series to cover infectious disease modeling concepts and relevant modeling research. Before we begin, I just want to mention some housekeeping items. We are running this webinar through Zoom, and if you run into any technical problems, please email us at nccid@umanitoba.ca. The Q&A session today will be focusing on today's topic, which is mathematical models of disease persistence in populations and how models of endemicity may be applied to the evolving COVID-19 situation. The session will be taking place in the Q&A tab. The hosts will use the chat tab for extra communication to participants, so please keep an eye on that tab as well. There's already some information there. The recording of this webinar, as well as the presenter slides, will be available after the webinar on the NCCID website at nccid.ca. And now I would like to introduce and welcome our two speakers for today's webinar. First, we have Dr. Amy Herford, who is an associate professor at the Memorial University of Newfoundland and Labrador in the biology and mathematics and statistics departments, with a cross appointment to the Faculty of Medicine. Dr. Herford is a mathematical biologist whose research applies mathematical modeling to population dynamics, ecology, and evolutionary epidemiology. Dr. Herford recently served as a member of the Newfoundland and Labrador Predictive Analytics Modeling Group and is a member of the Modeling Advisory Group to the COVID Immunity Task Force, the Canadian Network for Modeling Infectious Disease Mathematics for Public Health, and the One Health Network for Modeling Emerging Infections. Our second speaker today is Dr. Jane Heffernan, who is a professor in the Department of Mathematics and Statistics at York University and an inaugural York Research Chair, Tier 2, in multi-scale quantitative methods for evidence-based health policy. She is a co-director of the Center for Disease Modeling, president-elect of the Society for Mathematical Biology, and is a member of the Royal Society of Canada's College of New Scholars, Artists, and Scientists. She is a scientific advisor to the Canadian COVID Immunity Task Force and Health Canada's COVID Demand Modeling Group. Dr. Heffernan's research responds to the pressing need for new statistical, mathematical, and computational methods of mapping, understanding, and controlling infectious diseases, and aims to influence the development of new evidence-based public health policies. So thank you both for being here today. I will now turn over the mic to our first speaker, Dr. Amy Herford.
Thanks, Wendy. I'm just going to start sharing my screen. So I hope that that's sharing now. And if we're having trouble at all seeing the slides, please, if a moderator could just interrupt and let me know that there's a problem. So I'm a mathematical biologist. I'm a mathematical modeler. And I've worked in this area for 20 years. During the pandemic, myself and other individuals that are part of this community in Canada have done, I think, some important work that's helped inform public health decision-making during the pandemic phase. And I think we can build on these contributions to also make important contributions to other infectious diseases and COVID during the endemic phase. So I want to first start by just overviewing some of the types of contributions that people with expertise like me have made to the COVID response, and then outline some potential useful future directions for COVID when it's endemic. So I just want to narrow down on my specific interests and expertise a little bit, because modeling can mean so much. And so specifically the type of modeling that I do, I call it process-based or mechanistic modeling. And that contrasts with pattern-based or statistical or phenomenological modeling. So for phenomenological or pattern-based models, the goal is just to come up with a function that fits the data well. And oftentimes the parameters in such an approach will be an intercept or a slope coefficient. And the coefficients don't really have interpretations in terms of the epidemiology, like a transmission rate or a recovery rate. That's sort of an extreme explanation of what a statistical model is. There's a continuum, and sometimes these models do have interpretations that are in terms of epidemiological quantities. So if we think of the other end of the spectrum, are very strongly process-based models, and they aim to describe what we know about the epidemiology in a causation type framework, in a mathematical framework or an algorithm-based framework. And so, you know, for COVID, we have susceptible individuals, we have exposed individuals, we have admissions to the ICU and the hospital, and we put all that together in our function, and then we fit that to the data. And so this additional component to process-based modeling, which can mean that we can ask some different types of questions, but sometimes it can be hard to get a tight fit because there's this additional constraint of also needing to be faithful to the underlying mechanics of the epidemiology that we know is occurring. So everything that I talk about will be process-based or mechanistic models. During the pandemic, I want to highlight 3 important contributions that this type of modeling made: short-term forecasts, counterfactual scenarios, and for use in communication. This is a paper from Science that is talking about exactly this topic. I think it's interesting that they present this spectrum down the bottom of models, from ones that are making very strongly quantitative predictions on the right. And I imagine this as models that have age structure and spatial structure and a lot of complexity in them. But it's interesting that on the left, they're also talking about contributions that are coming from very, very simple models. They're calling them stylized facts. And I think of these as being just very like the susceptible, infected, recovered model with very little else in it. And something like that has been useful in the pandemic for communication. Case in point would be the amount of attention that was given to flatten the curve as to motivate the consequence that if we do social distancing, the peak number of hospitalizations would be reduced. And so that's more of a communication-based contribution, more of a stylized fact, but also, you know, something that models can do. So this graph gets 2 points across at once. It is not my graph, it's a published graph by researchers from Canada. And it's showing both short-term forecasts and a counterfactual scenario. The counterfactual scenario is, what if there was no variant of concern that had emerged? And so this one here is, in the purple is no variant of concern, and in the black you have the model with the variant of concern. And so you can kind of understand from a graph like this that, you know, infections would have gone down if not for the variant of concern coming along. This helps to contextualize and understand exactly the dynamics of COVID. And it's also a short-term forecast. But I look at a graph like this, and I think this is something that public health officials would find useful. to make decisions around planning. This is a graph that the public would find useful to see in order to understand, what exactly is going on in their communities with COVID and what to expect in the future. So I think this is a really worthwhile kind of graph to make. Mathematical modeling has also had a fundamental role during the pandemic in terms of communication. As official communication for organizations, these are slides from Public Health Agency of Canada. And within the slides, there's a graph that's specifically illustrating this type of process-based mathematical modeling. We've seen this from the Public Health Agency of Canada. We've seen it from provincial governments presenting modeling results. We've seen it from groups such as the Ontario Consensus Modeling Table, partner of the Ontario Science Table, and also from the independent BC Modeling Group. Many organizations using modeling to help inform the public. But also the stylized facts are helpful to communicate. There's not going, you can't always go into a lot of detail, and you just need to communicate the most important points. So I mentioned that flatten the curve as an example of a stylized fact that comes from modeling that has been very constructive. Another example of that is when the Omicron variant emerged, and we were hearing that it's a less severe variant because given that you're infected, you are less likely to have a severe outcome. On the other hand, we are also learning that it's very highly transmissible. And you can put those two facts together in kind of a simple stylized model and bring home the message that even though given infection, Omicron is less severe, combining that with the increased transmissibility would mean that the peak number of hospitalizations would be very high. So this is helpful to communicate in a very concise way, and it's something that comes out of this tradition of mechanistic modeling when we're trying to get down to the core essence of what's driving at conclusions. So now I want to shift and try and motivate that the contributions that have been made by mathematical modeling and process-based modeling during the pandemic phase of COVID, we can build on this relationship that we have with public health and also make contributions that are useful during the endemic phase. It would just look a bit different. So let's talk about what that might look like. I'm going to talk about two things: communicating around variant severity and also modeling variants of concern. Okay, so before we get into this, I want to talk about what we mean by endemic. And on the left, I have what I think the best textbooks out there for modeling infectious disease by Matt Keeling and Petra Hani. And I looked in the index for this book and looked at the mentions of endemic. And there was one mention of endemicity, and it was with respect to an endemic equilibrium. And I then used the model from the book and made a graph of the endemic equilibrium there. So in terms of infectious disease modeling, we think of endemicity as kind of a stable state where you have a non-zero amount of infection. You have the infection being prevalent, being present. So this type of vision of endemicity isn't really where COVID is going. COVID, I think, is going in a direction more similar to influenza, where it's not going to level off flat like this graph. If we want to be doing modeling for endemic COVID, we need to add to this framework two critical features: seasonality and the potential for evolution and the emergence of new variants. On the left is a recent graph that was talking about the title is, so this is a paper from Nature, is "Are COVID surges becoming more predictable?" And in this paper they talk about, they try to say yes, and that a new variant is arising roughly every 6 months. That graph is for South Africa, and it's not really what we've seen in Canada. For example, the second peak in South Africa is a beta variant wave, and I don't think we really saw very much beta variant at all in Canada. It was competed by the alpha variant, which was first detected in the UK. So then on the right-hand side, I have a picture of what waves have looked like in Canada. And we had the first wave in March 2020, and that was original variant, and then low levels of COVID during the summer of 2020. The next wave was in the fall of 2020, not known to be associated with a new variant. This is still the original variant. And so the second peak would likely be attributable to seasonality. The third peak came after the detection of the Alpha variant. The fourth peak is after the detection in Canada of the Delta variant. And then the fifth is Omicron, and then the sixth is BA2 Omicron. So in terms of understanding the long-term dynamics of COVID, considering variants is going to be very important, because 5 of these 6 peaks that are shown are associated with the emergence of new variants. So one thing that I think mathematical models could do to help communicate around COVID in the future is come up with a way to communicate variant severity. And if we go back to the idea of flatten the curve, that was, if you do social distancing and you reduce your net reproduction number, then you'll reduce the peak number of hospitalizations or the peak number of cases. And so usually pretty early in the detection of a new variant, we get this information about the transmission rate. I have some of this here, that the Alpha variant is 50% more transmissible than the original variant, that the Delta variant was 60% more transmissible than the Alpha variant, and that the Omicron is 3.3 times more transmissible than Delta. So you can combine that information into a mathematical model, and instead of explaining the implications of increased transmissibility in terms of RT, or net reproduction number, we could talk about what that implies for the peak number of cases and the peak number of hospitalizations. On the left is what was communicated about variant severity when Omicron first emerged. And I should point out that this is the percentage of reported cases that end up being hospitalized, but it is considering the amount of vaccination in place at the time. And so if you take the graph on the left, then Omicron is least severe because the fewest number of people are getting hospitalized when they're a reported case. It's about half as, by that metric, about half as serious as the other variants, most of those variants having emerged when there were very low vaccination levels, Delta also being on the severe end of given infection that you would be hospitalized or a fatality would occur. So if we just take that as our metric for how serious variants are, then it misses this point about transmissibility that was important to communicate with Omicron. In the middle, I have that graph that I showed previously about how the increased transmission can then be understood as a difference in terms of the peak number of cases. And if I put those two things together, then I get my graph on my graph with the green on the right there, where I'm estimating the peak number of admissions. This was just intended to illustrate the concept. It could be taken further with a concentrated research effort, but it does provide some broad scale agreement with the final graph on the right, which is showing the number of people that are hospitalized for different waves. It is showing that you had pretty high amount of peak hospitalizations for Omicron, and Alpha also showing up as high, which is broadly consistent with the pattern that we see in Canada. So that is an idea that I think could be taken further by someone with more concerted effort. Another question that comes up is how, over time, when would we expect a new variant to emerge? Is it 6 months, like the paper was suggesting in South Africa? And what kind of jump in transmissibility is going to be possible potentially with the emergence of a new variant? And so here I want to highlight 2 streams of work. The first is work by Troy Day and Sylvain Gondon, which is trying to combine ideas from population genetics with these process-based mechanistic epidemiological models. And one of the quantities that the model predicts in that framework is the change in the mean transmission rate over time. So the mean transmission rate, you're taking the mean across the variants, was low when you had original variant, and now when we're mostly into BA2, it's very high. So this would be an increasing function in this kind of framework that they have. We get at that. So there are a number of parameters in that framework that would be hard to estimate. Some of them are to do with mutation, and there's also some excellent work by Carmen Lee Morel and collaborators that are estimating mutation rates for COVID for different variants. It's not quite the same quantity that you need for the Day and Gumban model, but there's information there that if someone put some effort into, I think they could work with this framework to make some progress. Another quantity that you need in this method, which fuses population genetics with epidemiology, is you need to know the variance in transmission across all genotypes. And there's also the potential to get at that quantity as well. The paper that I'm citing in the bottom here is looking at generating hypothetical genotypes that could happen for COVID, and then modeling what they're expected, looking at the 3D structure and what would be the binding affinity between the spike protein and the human ACE receptor, which should give you some idea of what transmissibility is. And in panel C there, you've got this frequency histogram for number of variants and binding affinity. So that is getting close to what you would need to estimate there again to apply that framework. So again, this could be put together to predict something like increase in transmission rate over time due to emergence of new variants. And so the last thing that I wanted to say is that in terms of process-based modeling for public health, I feel like there was a lot of progress that was made during the pandemic. I would love to see that continue during endemic COVID and for other infectious diseases into the future. Modeling became kind of a provincial thing during COVID, in part because health is a provincial jurisdiction. And I think there is a need to build provincial public health capacity for modeling. A lot of the modeling capacity was put together at the provincial level during the pandemic. There's also a question of whether we would really need to be doing different models for all the different provinces. I spent a lot of time during the pandemic phase of COVID doing modeling for Newfoundland and Labrador. There were certainly occasions where I think it was helpful to be modeling for a specific province. Some examples would be during the Omicron wave, I did some short-term forecasting. At the time when it looked like BA2 was rising in Ontario, Newfoundland and Labrador was also rising, but due to my knowledge of the measures that had been implemented and to modeling that I did on the data, it seemed that the cases were rising in Newfoundland and Labrador for a different reason. And so it was helpful to have had that experience modeling locally. For counterfactual scenarios, sometimes the needs were different in Newfoundland and Labrador than they were for other provinces. There were strong travel restrictions, and some of the counterfactual modeling that we did was looking at the impact. And also just for communication, having lived in the same province that I'm doing modeling for, having listened to the chief medical officer talk about what restrictions we were having and why we were having them, I think was really useful for my communication during the pandemic. So I wanted to acknowledge groups that have been really helpful for me for being part of to get ideas for how other people were doing their modeling. The Newfoundland and Labrador Centre for Health Information, Public Health Agency of Canada, and also acknowledge financial support from NSERC, the Canadian Network for Mathematical Modeling, Mathematics for Public Health, and the One Health Network for Modeling Infections. So thanks very much.
Thank you, Dr. Herford, very much for your presentation. Definitely some really excellent points made about communication between modeling researchers and public health and what we might need in endemic models for COVID-19 moving forward. So just a quick note that we are keeping track of questions in the Q&A tab for the question period at the end of both of the presentations. So please do keep the questions coming in. We will try to address as many as we can at the end. And so now we will move on to our second presentation by Dr. Heffernan.
Thank you. So I'm going to build on what Amy was just talking about and talk about what we might need in models of the endemic stage of COVID-19. And so you can think about all the different pathways that COVID-19 can take. We talked already about, what variants of concern or different strains can do. There's also behavior. Has the population shifted in behavior to something that will be more socially containing of infectious diseases? There are a lot of things that we need to consider, as well as just geographic location, just different distributions of age groups and contact structure, and so on. And so Amy showed a graph of what endemic looks like to a mathematician, and she talked a little bit about fluctuations, but I wanted to say that, so this is a graph that I got from a textbook. The reference isn't appearing, where here you can consider this like the epidemic stage of an infectious disease, but endemic can go along over, like there can be bumps or it could be more smooth and so on. And what I'm showing you on the right-hand side is what endemic influenza looks like in different countries. So here we have, we know that we have influenza seasons, but we know that influenza is endemic to the globe and in different countries. And you can see what the seasonality looks like. You can also see how the seasonality is different for Australia versus the rest of these countries, because we've got southern hemisphere seasonality and northern hemisphere. You can see how different seasons affect each country a little different. And then the bottom, what I have here is what measles outbreaks look like in different areas of the United Kingdom, pre the vaccine era and after vaccination rollout. And you can again see the seasonality of the measles outbreaks. You can also see how the number of cases can be quite large for one particular location, but still small for another location. And after the rollout of the vaccine and then even more rollout of effective vaccination, you can still see that there's some seasonality, and then there could be some small outbreaks in vaccinated populations that aren't significantly vaccinated. And so what we're really interested in looking at in my lab is how immunity is going to affect the endemic stages of infectious diseases. And so you can think about when you're in a population like Toronto, we have lots of individuals who are moving around this population, and every individual has a different immune system. And their immune system is going to affect how susceptible they are. So all of the infection history that they have and the immune system that they have inherited and grown up with. And so when we think about their susceptibility, whether it's susceptibility to infection or if they are infected, the immune system is also going to affect how sick that person can feel, which is going to change their behavior, whether they stay home from school or work, or they're feeling okay enough that they might go out and about and do their grocery shopping and go to work and so on. But their immune system is also going to affect their pathogen load in the body. And so it's going to affect their transmissibility back into the population. And so we're really interested in looking at what the distribution of immunity in the population looks like. And that means then that we have to understand what immunity looks like in individuals so that we can understand what the distribution of immunity looks like in a population. So we model how the immune system and a pathogen interact and how you get immunity from that interaction. And we model how protective that immunity is in an individual. So we expose our computerized individual to an infectious disease, and then weeks later we expose them again, and years later we expose them again, to see what how protective the immunity that they gain from an infection is from consecutive infections later on in time. Then looking at these curves, we can also try to quantify how sick someone will be. And then we can do the same thing for influenza. We challenge the in-host immune system, our computerized individual with a vaccine, and we look at how they develop immunity and what their different paths of immunity and exposure to infectious diseases or booster doses of the vaccine look like over time. When we talk about individuals in a population and we talk about how sick someone feels, then we also have to consider how individuals behave. And what's really interesting about modeling behavior is that you can think about it in a similar way as to modeling immunity, where you gain positive behavior in terms of restricting your susceptibility, so reducing contacts or wearing protective equipment to help stop something from infecting you. So there's those behaviors, but then and you've experienced probably over this pandemic that your behavior can also wane over time, and then maybe with a new wave, your behavior will become more restricted, or you start wearing your mask more often, and then your behavior can wane over time, and so on. And when we model our immunity in our individuals, we also have to consider that we model the increase in immunity that an individual gets from infection or vaccination, but then we also model how that immunity can decay over time, and whether and how that immunity decay affects your probability of infection, but also your probability of getting a severe infection if you do actually get infected. So then what we're really interested in at the population level looking at is these distributions of immunity in many different geographic locations, and considering the cohort of individuals in the geographic location as well. And so you can consider different rates of immigration into, say, different Canadian cities. And so we have a different makeup of different ethnicities in Toronto versus in Regina. And so our distribution of immunity could look quite different. And so that's something that we try to quantify here. And then that means that this can also affect how we observe an endemic infection in a population. Okay. And so, like what Amy said, when we're looking at a mathematical model, an endemic is defined as looking at the number of new infections coming into the infected class is equal to the number of infections leaving the infected class. You get that infected equilibrium. But what we do know that endemic diseases have seasonality, and so we can build in seasonality into our mathematical models, and that can, one, have to do with the effects of humidity and temperature on how a pathogen can exist in the environment, or how it aids the flow of virus particles in the air to other people. It can also affect our behavior. So our behavior is different seasonally. We act very differently, and we go to different places in the summer than we do in the winter, for example. We also have changes in public health activities and administration that can also induce waves in our infections. And then, of course, we have to consider changes in transmissibility of the different variants. And then, as a side thing that I've been considering during the pandemic is how these different waves, every time a new variant has come into the population, how this is going to affect healthcare demand in terms of hospital beds, and as well as personal protective equipment needs, as well as you can think that this is also going to have an effect on prescription drugs that we have in our pharmacies and so on. Okay. So if you think about a mathematical model, what I wanted to show you is one that we have been looking at, that we are using to look at scenarios of endemicity. So here we have individuals that are in different susceptibility classes. So individuals that are in this susceptibility S1 are entirely susceptible to an infection to COVID-19, say. And then in S4, they're entirely protected from infection. And then in S3, they have some protection from infection and severe disease. And in S2, they have some as well, but less than S3, and they're not fully susceptible like S1. And then what we do is we have individuals move through mild, moderate, and severe infections with specific probabilities. And the probability that they go through these different disease classes depends on the comorbidity status of the individual in the population. And that's highly correlated with age. So we use distributions of comorbidities in the age groups to determine what mild, moderate, and severe infections will look like in the different age groups. This also then means that if we have different types of infections, we know that this is going to affect the reporting rate. So severe infections would be reported because they would need some sort of doctor's appointment or maybe go to hospital. Moderate infections have some probability of reporting. And then our mild infections have a lower probability of reporting because these are very asymptomatic and probably not very detectable by an individual unless they just go get tested. So we're interested in looking at what this distribution of immunity of individuals in these different S classes and these different infections are going to look like, not just in an epidemic stage, but in endemic disease. And then if you think about for influenza, we have booster doses every year or some influenza vaccine. There's discussion as to what COVID-19 booster doses might look like in an endemic stage of COVID-19 disease as well. And so you can think about, so this is looking at like first dose and second dose that we had back in 2020, 2021. But we can cook in also booster doses of the vaccines in the population and then look at how immunity gained from infection and or vaccination and combinations of all of those things and mixing and matching of different vaccines from year to year or dose to dose, what that is going to do to the distribution of immunity in the population, which will then help define what endemic level the population will experience for the infectious disease, along with, of course, behavior, variants of concern, and then just the effects of temperature that overall have an effect on transmissibility as well. And so this type of model includes the increase, the compliance and relaxation of mask wearing, so personal protective equipment, social distancing compliance and relaxation, because it incorporates age as well. So we can look at how individuals at different age groups modify their contacts over time. It also includes testing rates and contact tracing rates, so government activities, as well as changes in virus transmissibility over time. We can incorporate that into the transmission rates and the effect of weather on the transmissibility as well. And so when we're looking at the endemic state, we really want to quantify what this distribution of immunity looks like in the population. That's going to help us determine, say, if booster doses are needed in specific cohorts or if they're needed at all. And we also want to look at what our underreporting rate is going to look like in the endemic state. So we know that for influenza, not all influenza infections are reported because people stay home. And we have reached somewhat that already in COVID-19 and over the Omicron wave. So individuals have detected through rapid antigen test or just because they have symptoms, they stay home, and not all infections with symptoms then were reported. Severe infections requiring healthcare would still be reported though. We need to also consider what the underreporting rate of COVID-19 will be in the endemic stage as well. Okay, so here I just wanted to show you what a disease model can actually help us understand. So if we look at here, the red are individuals that are in the S1 class, and so they're totally susceptible to the infectious disease. Blue, they have a little bit of immunity, red, a little bit more, and green, they're fully immune to infection. And so you can see here then, if we look at different age groups, So this is 5-year age groups. We can use mathematical models to determine what age groups have suboptimal levels of immunity, which could be, could inform public health policy or, programming to see what age groups maybe should have a booster dose of a vaccine. When we look at mild, moderate, and severe infections, what might we think we observe in an endemic stage of mild, moderate, and severe infections? And then when we look at just severe infections, what age groups are going to be mostly affected by severe infections, which can also then help us determine what kind of public health, programs are going to be needed in different endemic waves of the disease, as well as just from year to year, and with waning immunity and waning and immunity build up in the population. So the distribution of immunity is really going to matter. Okay, so just a reminder that endemic stage doesn't mean that the disease will always be observable. There are periods of time when we don't see influenza in the population very much, like in the summers, but then we have our influenza seasons. So even though we're not observing something doesn't mean that it's not endemic in the population. It's also important to note that different geographic locations are going to experience endemicity differently. And it's also important to note that our endemicity that we experience in our population is going to depend on the immunity distributions, vaccination programming, which affects immunity distributions, the contact structure, so our social distancing or physical distancing, our mask wearing, as well as the variants of concern, and as well the effects of the climate and weather on the transmissibility of the infectious disease. So we have many different pathways to endemicity that we can still take. We're not in an endemic situation. Even when we are in endemicity, our level of endemicity can change depending on all these other things happening in the population over time too. Maybe the population is on average becoming more compliant to public health interventions and mask wearing. We'll have to see. So these are all the things that you want to consider, and they just reiterate what Amy was saying too in terms of behavior. We've got issues of behavior, public health interventions, changes in the variants of concern, and the effects of weather on what endemicity will look like for COVID-19. And so just one last thing, that when we're looking at mathematical models of infectious diseases, we always have to make sure that we're looking at something that's simple enough so that we don't incorporate a ton of uncertainty into the model, given the data that we have, but also complex enough so that we can get new knowledge from results. And so when we're developing our mathematical models, we're always trying to optimize new knowledge given a specific level of simplicity in our mathematical models that are determined by the level of data or the amount of data that are available for us to use. So I just wanted to acknowledge some funding bodies. So specifically, this work has been funded by NSERC, the Public Health Agency of Canada, and CIHR. And it's also been, and the Canadian Immunization Research Network, and it's also been supported by Health Canada and the COVID Immunity Task Force, as well as the National Research Council of Canada. Thank you.
Thank you very much, Dr. Heffernan. And so thank you to both our speakers for your presentations. As we move into the Q&A period, I would like to remind everyone that this session will take place in the Q&A tab. We've already been able to answer some questions in there, So if you would like to ask more questions, please drop them in the Q&A tab. You can also like other people's questions to push them up in priority. and we'll try to address as many as we can right now. So we got a couple of questions related to things and different factors to include in the models. And we're interested in how these models at this point are able to differentiate the ways in which different interventions, social distancing, vaccination, are impacting these future spikes in infections. And also, I would also like to ask how these different interventions might be actively selecting for new variants. So maybe turn to Dr. Heffernan first.
So in terms of looking at incorporating these different components into models, it really does depend on the availability of data or previous studies. And so if we look at incorporating behavior into a model, we do have some knowledge as to how contacts have changed over the course of the pandemic in different provinces through a CONNECT study with the Canadian Immunization Research Network and other contact tracing studies, as well as there's been we use these contact structure matrices, how different age groups have contact with other age groups over time in different days of the week even. And we can modify those given that we know, say, maybe schools are closed or businesses are closed. And so we can modify the number of contacts that on average that we believe people will be having, given what's been known already about how people have been changing their behavior. And then in terms of incorporating different transmissibilities or characteristics of the variants of concern, we can incorporate knowledge that we get from the beginning of each one of these waves as to what the reproduction number is for each variant of concern, like how transmissible it is, and then also look at the efficacy of the immune response in staving off infection or severe disease very early on in each wave. And then we can incorporate those into specific parameters having to do with susceptibility and probability of mild, moderate, or severe infection into the model very early on. So we can look at different scenarios of what each wave will look like.
Thank you. And then Dr. Herford, did you have anything to add to that point?
Yeah, I mean, I agree with what Jane said, that it depends a bit on what data you have to independently estimate parameters. For vaccination, usually there's quite a bit of information that comes out pretty fast, with thanks to the United Kingdom for providing that information on vaccine efficacy against transmission and severe disease. So vaccination is generally quite easy to incorporate as a counterfactual because so much information about vaccine efficacy comes forward. In some of the questions that I answered there, yeah, I should clarify that when I was talking about seasonality, there's ambiguity about what will be driving that seasonality. If it's kids going back to school, or it's generally behavioral shifts. I think past results have showed more than humidity or any environmental thing. So I was really just talking about a temporal shift and what exactly the mechanism is. That would depend on how much evidence there was to look at different scenarios.
Right. Thank you. We have another question from an anonymous attendee asking about what has been done to incorporate health inequities into COVID-19 modeling, and especially from if we're moving from the pandemic to endemic perspective, how including some of this demographic data, which I believe Dr. Heffernan also mentioned for her model, how these can be used to address issues related to access to care or to better support communities that are disproportionately affected.
Yeah, so GBA plus, I guess, gender-based analysis plus, including ethnicities and different ages, can be certainly incorporated into mathematical models, especially if you're looking at specific geographic locations or different cohorts of a population. And so while I was showing you a disease model that was split up by different age groups, it can be partitioned into different cohorts of a population as well, or even in different geographic structures. So if you're looking at the GTA, then you can have different suburbs of the population and the mixing between the different suburbs differently. But we do know too that from some of the studies that some of the increase in burden of COVID-19 on specific population groups is also depends on the type of work that people are doing and whether they were required workers or workers of necessity, I guess, during the pandemic. And so those are things that we need to consider too in terms of how not just models, but even like epidemiologists in public health and how we can also help control infections or exposures in specific workplaces as well.
Right. And I think that geographic locations also kind of points back to what Dr. Herford was saying about modeling at a more provincial level. That might give us a better idea of what's going on. So Dr. Herford, would you mind elaborating a bit on your ideas for provincial level modeling?
Yeah, maybe I'll come back to that, but I think, I wasn't thinking about it specifically in that context. One thing that I wanted to highlight was, I think the research program of Sharmista Mishra, I think she's at Sunnybrook, is really about trying to understand how we can do a better job of incorporating health inequalities into modeling. And I think for the Mathematics for Public Health website through the Fields Institute, I think you can watch one of her talks before. She did a really nice job of explaining that the optimal public health strategy at the population level is not necessarily the equitable one. It doesn't share, it's not optimal in terms of sharing the responsibility across different groups. I think this became really obvious when a lot of provinces wanted to reopen and some people were saying, I'm immunocompromised. And, public health was saying, well, we're doing what's best for the population. So this seems like, I'm excited for Sharmista's research program. It seems really relevant to be thinking about what level of heterogeneity needs to be included and how we can go about those problems. I was also reading a book at Indigenous Statistics, and it was talking about how there's a conflict between the way that we go about mathematical modeling and that we're modeling to the average, but in terms of incorporating, groups that are disadvantaged, they get averaged out and not considered in a fair way. So I think the work that Sharmista is doing is really good in this respect. And in terms of provincially, it's hard. I think of this as at a smaller scale level where it's individuals that have to go to work in the grocery store because their boss doesn't want them to have any sick leave, and that's the kind of inequality that I was thinking about more when that question was originally posed.
Yeah, I think those factors, in addition to other demographic factors, are important to consider as well. So on the topic of data to include in models, I believe we had a question on this already, but I would also like to ask for anyone who might have missed it. So when we're thinking about model complexity versus a more parsimonious model or a model that is just simple enough to be able to answer our research question, what would you say are some key pieces of data that we are still missing? So some gaps in the data that you would really like to be able to develop a better informed model of COVID moving into a more endemic phase. Maybe yes, Dr. Heffernan, please.
We're going to say that there's always a need for better and more data, or a want, I guess, is better to say. But yes, so there still are a lot of questions regarding susceptibility and severity of infection in children. So, and what vaccination outcomes look like in children as well, especially in the younger age group when there's no vaccine really, so what that's going to look like. But also in terms of trying to distinguish between who has been tested because they have a severe infection versus who has been tested because of contact tracing or just because they were going to go visit grandma and went to get tested, or they were going to travel. And understanding more about hospitalized because of COVID and hospitalized with COVID, there are a lot of differences in that. There's a lot of still issues in the data. So we have data that we can use, but I guess it's really looking at certainty in the data that we have, and then what extra bits of data can we get to help us, I guess, deal with the uncertainty in the data that we have too, if that data can't be further delineated, like, changed into appropriate contexts that are easier for us to align with.
Right, thank you. And then Dr. Herford, any additional points?
I think it's a really good question, and I think my answer is going to be really unsatisfactory. When I was doing my PhD, I remember there was a call out to work on a research project that was asking the question, why was the second peak in the 1918 flu epidemic higher than the first peak? And that was a big question. And now, having lived during a pandemic, I feel like it would be so much easier to answer that question, having actually been there at the time and not lost 100 years of information. I don't really know what that means for COVID, but during the pandemic phase of COVID, it was amazing how much data there was. And, even some sources of data like Facebook or Twitter or kind of social information, I would just love to see us be able to archive that data. So if in 100 years someone was to ask a similar question, it's still there. And I kind of agree with Jane. During the pandemic phase, we had so much data, and I felt like I had some confidence in reported cases. But with Omicron, the PCR capacity got exceeded and things got really confusing as to what reported cases meant. Recovering some of the information about what are the testing criteria to try and recover what true cases might be. But there's also reliable ways of estimating that. The work that the COVID Immunity Task Force does with serology is really good. The recent StatsCan survey that went out to ask people to, I think, submit blood test results again around random surveys and have you had COVID? So this is really important initiatives, and this is a really good question to think about what is the most important data and to try and archive it while we can.
I also just wanted to say too that the frequency at which measurements are taken in a population, like weekly versus daily versus biweekly, that can also change how the importance of some data sets over others. And so just also like thinking about frequency of data, like we're used to for flu, just getting things weekly. With COVID, we were getting things daily. We need to consider that as well.
Perfect, thank you. And in the interest of time, I'm going to ask one last very interesting question before we close off. Heather is asking that given the recent confirmed cases of monkeypox in Canada, what are the opportunities and challenges for math modelers in public health to draw on models of monkeypox transmission in endemic countries and apply them to the Canadian context? Maybe start with Dr. Herford this time.
Oh, it's a really hard question with no time to think about the answer. I think it's a really good question, and drawing on the previous work that's been done, COVID was a novel virus. A lot of information came out rapidly, but there's existing work on monkeypox. There's expertise in the countries that have endemic monkeypox. So I would start by reading what's been done there, and then try and think about the implications for Canada.
I'll say that the way that monkeypox is transmitted is very different from COVID-19. And so there are things that we need to learn about how to, change parameters and models if we're going to provide a lot of modeling, resources onto monkeypox. There are some diseases that are easier to control over others. And so it also depends on that, how much time modelers will spend. But it's also important to note that early on, if there isn't a lot of knowledge about something in a geographic location, that there can be some models that could be very way off, and provide some projections that retrospectively were way off and don't make a lot of sense. But it's also, when you do get projections like that into the public, individuals do change their behavior too. And so we need to consider what way off means, and we need to also consider what people already know in other geographic locations into our models too.
Right. Okay. Okay, so we will wrap it up. Thank you so much to Dr. Heffernan and Dr. Herford for your presentations today. And thank you all to our participants for joining this webinar. We hope that this information will be relevant to your work moving forward. So again, a reminder that the recording and slides from today's webinar will be available on the NCCID website after this webinar. So thank you again to our speakers and our participants, and have an excellent day, everyone. Bye-bye.